Welcome to DDAP's Technical Assistance webinar for the month of July. Today's topic will focus on the upcoming ambulatory on-site alignment reviews. As a reminder, alignment of the ASAM criteria is required for treatment providers that receive funding and provide treatment services under agreements with single county authorities and managed care organizations. DDAP strongly suggests reading the ASAM text in its entirety, attending the ASAM training, and reviewing the resources available through the DDAP documents and training located on our website. At this point, I'm going to turn it over to Lori from Mercer to identify today's learning objectives.
Hi, everybody. My name is Laurie Clancher, and I'm a consultant with Mercer who's been working with Pennsylvania on the 1115 demonstration since 2018. Wanted to take a moment to review the learning objectives and let you know what you can expect from this training. The first is that participants will gain an understanding of the purpose of the ambulatory level of care alignment reviews. Providers will understand the expectations of the alignment review and their role, and participant questions about the plan for the alignment reviews will be answered. Slide. Today's presenters are myself, Laurie Clancher, Brenda Jackson, and Stacy Smith. And I'll turn it over to Stacy, or I'm sorry, to Brenda.
Thank you. If you could go to this next slide. The 1115 demonstration provides the Commonwealth with federal funds for large substance use facilities with more than 16 beds that are traditionally not funded with Medicaid. We are in the 8th year of the demonstration. This is the second waiver period. This waiver is approved through 2027. The demonstration requires the Commonwealth to establish standards that align with the American Society of Addiction Medicine 3rd edition. We will be working through what the requirements are and how ambulatory providers will be reviewed to ensure that the services that are offered are in alignment with the 3rd edition ASAM. Two of the specific requirements under the demonstration are milestone number 2, the use of the ASAM patient placement criteria, which includes the use of the ASAM 6 dimensions in assessment and driving treatment needs. Number 2, access of services at the appropriate ASAM level of care. And number 3, interventions appropriate for the diagnosis of and ASAM level of care. Milestone number 4 is the assessment of the availability of providers who are accepting new patients for all critical levels of care, including ASAM ambulatory levels of 1, 2.1, and 2.5, as well as ambulatory withdrawal management and medication-assisted treatment. For the next slide, I'm going to turn this back over to Stacy.
Thanks, Brenda. A BIMCO will be contacting ambulatory substance use providers to schedule an alignment review. They will request policies and procedures to be provided in advance, and this component of the review will take place remotely. The BIMCO will also request medical records for review, no more than 2 per ambulatory level of care. The record review may take place on-site or remotely, depending on the BIMCO and the provider. Next slide, please. This review process focuses on how closely the agency's policies and procedures and their implementation of those policies and procedures align with the ASAM 3rd edition criteria. The review will identify both areas of strength that agencies should continue to implement and support, as well as areas of opportunity where improvement could better align practices with the ASAM criteria. If any issues are identified that pose a threat to beneficiary health and/or safety, or if program integrity issues are identified, reviewers will follow up with the provider, primary contractors, BIMCOs, SCAs, fraud, waste, and abuse staff, and potentially licensure staff as needed. The review score impacts the follow-up review requirements, with programs scoring a 3 or 4, creating corrective action plans within 60 days of final findings, providing a status update in 6 months, and completing a re-review within 1 year of final findings. Programs scoring a 2 will complete a subsequent review in 2 years, and programs scoring a 1 will complete a subsequent review in 3 years. I'm going to turn it back over to Brenda.
Thank you. As noted on the previous slides, there will be reviews and then continued re-reviews until providers are able to meet the requirements of ASAM. We are going to highlight today the requirements of ASAM 1, 2.1, and 2.5, but the slides that we have shared will also have specialty consideration requirements at the end in the appendix. They also have ASAM 1, 2.1, and 2.5 requirements for adolescent, co-occurring enhanced, withdrawal management, and other specialty considerations. Our goal in sharing these slides today is to hope that all provider agencies will review their internal policies and procedures in the next 6 months and ensure that all of these items are included. To assist with this analysis, Mercer has prepared some example policies and procedures, including these items that will be shared with provider agencies with the slides and that can be utilized to help provider agencies address these ASAM requirements. This particular slide outlines the basic ambulatory ASAM requirements for provider assessment policies and procedures for ASAM 1, 2.1, and 2.5. For example, the review will check providers to make sure that they have a policy and procedure that outlines the correct ASAM criteria for admission for each level of care in the facility. The review will ensure that the assessment, treatment plan, and continued stay criteria match the ASAM level of care. We are not going to review every bullet from the slides, but keep in mind that these bullets are taken directly from the review tool and constitute what the actual policies and procedures of the providers will be reviewed against. So for example, if we go to the next slide, this slide outlines the basic ambulatory ASAM requirements for utilization review, continued services, and transfer and discharge. For example, the policies and procedures will be reviewed to ensure that there is not a fixed length of stay, such as an 8-week IOP program or partial hospitalization program. Also, there will need to be a procedure or a protocol for completing continued stay reviews, and the protocol will need to incorporate all 6 dimensions of ASAM. Also, the provider will need to have a process in place to ensure that the duration of treatment varies with the severity of the individual's illness or his response to treatment. All of these elements will be considered critical to passing the ASAM alignment review. If you go to the next slide, this slide outlines the basic ASAM requirements for interventions. Interventions need to be appropriate for the diagnosis and level of care. For example, you can see that all levels will need to have addiction pharmacology used in the treatment of OUD prescribed or offered in one manner or another. If the provider does not offer it themselves, then they need to be able and willing to accept beneficiaries and provide and members who are on those medications into their caseload. If you go on to the next slide, I'm going to turn this over to Stacy.
Thanks, Brenda. This slide outlines the basic ambulatory ASAM requirements for types of services for ASAM level 1.0. ASAM 3rd edition indicates that providers of level 1.0 should have policies and procedures guiding the development of individualized treatment plans with beneficiaries that document the type of skilled treatment services the program will provide and the amount, frequency, and intensity of services to meet the beneficiary's needs. if a beneficiary has a co-occurring mental health condition, the treatment plan should address issues regarding psychotropic medications, mental health treatment, and how they impact the beneficiary's substance use disorder and treatment as needed. The treatment plan should also support the integration of primary medical and general medical care. Next slide, please. ASAM Level 2.1 providers should have policies and procedures reflecting a minimum of 9 hours a week of skilled treatment services for adults and a minimum of 6 hours a week for adolescents, the discrete type of services offered to the beneficiary, as well as the amount, frequency, and intensity of the interventions. Policy and procedure language should indicate that if a beneficiary is not able to safely transfer from level 2.1 to a level 1.0 outside of the agency, the treatment for level 1.0 may be continued in the current level 2.1 provider, and there should be documentation identifying when this should occur and for what reason. There should be policies and procedures addressing the engagement of family and care, as well as policies and procedures ensuring that therapies and interventions offered are adapted to the beneficiary's developmental and comprehension level. Interventions should include motivational interviewing, enhancement, and engagement strategies as opposed to confrontational approaches. These interventions should be offered to beneficiaries with co-occurring mental health disorders that are able to benefit from a planned program of therapies. Next slide, please. The policies and procedures for ASAM Level 2.5 services offered should reflect a minimum of 20 hours a week of skilled treatment services. The guidance for individualized treatment planning, types of services offered, family engagement, and use of motivational interventions aligns with the requirements of ASAM Level 2.1. Next slide, please, and I am going to pass it over to Lori.
Thank you. And next, we're going to talk about staffing requirements for each level of care, starting with level 1, or ASAM 1. So this slide outlines the basic ambulatory ASAM requirements for staffing and hours of clinical care for ASAM 1. A lot of the language refers to appropriately credentialed and/or licensed treatment providers. Now, ASAM does not specifically define what those are, but services should be delivered by clinicians with the education, training, and experience necessary to provide the clinical interventions that are appropriate for the member. A licensed medical practitioner with prescribing authority is needed for pharmacologic interventions. And your policies, program descriptions, job descriptions should reflect what the level of education, experience, licensure, et cetera, that is required for the position, whether that's at hire or within a certain period of time post-hire. Your policy should also reflect your process for collaborating with other professionals as necessary. I think it's also a good time to mention the ASAM training resources for staff. You'll hear about this, you heard about it earlier, and you'll hear about it later, but the expectation is that staff receives ASAM training within 365 days of hire, and a supervisor is required to sign off on assessments until that is completed. And ASAM does offer online trainings, specifically for newer people, a 2-day foundations and skill building course. Next slide. So this slide outlines the basic ambulatory ASAM requirements for staffing and hours of clinical care for ASAM 2.1 and 2.5. And since these are more intensive services, they are typically team delivered and include positions like a program director, treatment staff, which could include licensed and credentialed counselors, physicians, and peers. Again, the policy should outline the position requirements and the scope of practice. The training requirements at hire or within a certain period of time post-hire should be documented. And since the person's receiving treatment in these levels of care will likely have higher needs in general, and we also know that many people have co-occurring mental health symptoms or diagnoses, it's important that you have staff trained to recognize the need for co-occurring treatment or have an understanding of mental health to identify if additional supports are needed. Slide. Slide outlines the basic ambulatory ASAM requirements for care coordination. And it's important that we think about care coordination as a concept, not just a specific job title. When ASAM refers to care coordination, it's really just as the words imply, coordinating necessary care services for a person either within or outside of the program. There are some time-specific parameters for psychiatric and medical consultation based on the level of care, and your policies should reflect your process for that. So for example, ASAM level 1 says that medical and psychiatric consultation is available within 24 hours by telephone, or if in person, within a time frame appropriate to the severity and urgency of the consultation requested. So with that, it allows you as an agency to determine what your idea of urgency might mean. But for 2.1, the requirement is that it's 24 hours by telephone and within 72 hours in person. And in 2.5, it's that the psychiatric and other consultation is available within 8 hours by telephone and within 48 hours in person. Next slide, please. This slide is a grid that includes the ASAM 3rd edition page references for the requirements. And it should be noted, if you have the online version of ASAM, the page may be off by 1 or 2. But most level of care chapters for the ASAM are structured by examples of service delivery, the setting where the treatment can occur, support systems, staffing, therapies, assessment and treatment plan reviews, and documentation. So they all follow a similar flow. And next slide, please. We've spent most of the time talking about the infrastructure portion of the alignment review, but also wanted to touch on the record review portion too. So as Stacy mentioned before, typically the infrastructure review is conducted first, followed by the record review. And the reason we focused on the infrastructure for this presentation is because that's really your foundation for alignment. The policies and procedures, they're formalized in writing. The staff training provides clear expectations of their role and performance. And then the record reviews come in and they demonstrate the implementation of and the adherence to the infrastructure. And this can be assisted by things like job aids and documentation templates to support and guide your employees. And you can also monitor this internally during supervision or more formal QI activities. Slide, please. All right, the record review, there's a demonstration of key treatment components, and these are something that you've no doubt heard before. These are the key treatment components. That ASAM criteria is used to determine the level of care for admission and continued stay. That a comprehensive biopsychosocial assessment is completed that includes the 6 dimensions of ASAM. That a treatment plan is individualized and developed with a recipient. Treatment length of stay and therapies are individualized. Education, assessment, and referral, if desired, for addiction pharmacology is completed and offered. There's care coordination for clinical and non-clinical needs, and discharge and transfer planning occur. And so when a file is being evaluated for alignment, in order to avoid scoring a 3 or 4, these are the key treatment components that you want to demonstrate are being delivered. Next slide, please. So these are some recommendations for you to get ready for the record reviews or for the alignment reviews, both the infrastructure and the record reviews. So our suggestion would be that you review your policies and procedures and your program descriptions to ensure that they're current. And you can compare them against the ASAM requirements, the sample policies that are included with this presentation, and the content on this slide, which really includes a lot of the content from the ASAM book. And then you can develop or revise your materials as needed. Once you have your paperwork and policies and your infrastructure squared away, you want to make sure that you have a plan to operationalize the practices if they're not in place already. And this is where things like creating documentation templates and job aids will help to guide your staff to remember all the things that need to be included in progress notes or treatment plans and things like that. Of course, you want to train staff and also provide support and resources. And then again, you can utilize the QI process to evaluate your progress and identify any opportunities that need to be addressed. Okay, next slide, please. This is the timeline. And the plan is that the ambulatory reviews will begin in January of 2026. The information that will be collected at that point will be general information. So those are things like the levels of care that you offer, what your capacity is at the time of the review, and your availability to take members. Gather information on the infrastructure review, and then the record review, which is a minimum of 2 per level of care. The way this will be rolled out is a focus on providers who offer really things higher than ASAM 1 outpatient, case management, and smoking cessation. So the focus is going to be on providers who offer level 1 opioid treatment programs, level 1 withdrawal management, level 2.1, and level 2.5. The other levels of care will be reviewed later unless they're offered as part of any of the services above. The goal will be to complete all the initial reviews by December of 2026. And if you remember back to the slide of the timeframes, I just want to point out that those re-review timeframes and process differs from the residential levels of care. The goal is to not have anybody receive a re-review before everyone has had a initial review. Next slide, please. So any questions that you have regarding this presentation or ASAM alignment, you can direct to DHS, and the email address is listed there. Next slide is just a helpful link to service characteristics and checklists that DDAP has developed. And these would be useful for you to make sure that you're working towards a program that's in alignment. We aren't going to go through the slides in the appendix, but did want to talk about them. And these are slides 25 through 36. And what they really include is information specific to more specialty types of programs. So withdrawal management, programs that are co-occurring enhanced, and the adolescent populations. So the slides follow the same format as we reviewed for kind of the standard levels of care. They just include specific differences that would be necessary for withdrawal management, co-occurring enhanced, and the adolescent populations. So you can see them there.
Great. Thank you so much, Lori, Brenda, and Stacy, for all of this great information. This concludes this month's TA call, and we'll see everyone at 10 a.m. on August 4th.